One of the hardest things in medicine is navigating conditions where the patient experience is very real, but the specific framework being applied to it sits outside mainstream medical evidence. And for many people dealing with chronic inflammatory symptoms, the journey itself actually becomes part of the illness. Years of uncertainty, fragmented care, and feeling caught between dismissal and over-explanation. In today's episode, Lauren Lowenstein, the Biotoxin Lady, is going to describe her journey to find relief from symptoms including fatigue, cognitive dysfunction, muscle and body aches, mood swings, increased urination, numbness and tingling, and visual disturbances. Initially diagnosed with MS, Lauren found her diagnosis of Chronic Inflammatory Response Syndrome. Sitting outside the mainstream of medicine, learning about CIRS, acting as her own advocate, Lauren will tell us how her story ended.
Welcome back to Vital Discourse. I'm Dr. Ben. I'm here with Dr. Lee, and we are joined by Lauren Lowenstein, also known as the Biotoxin Lady. Lauren focuses on environmental biotoxins, mold illness, and chronic inflammatory response syndrome, also known as CIRS or biotoxin illness. Her work centers on helping patients and practitioners better understand chronic inflammatory illness linked to environmental exposures. Lauren, so glad to have you here. I think the place we need to start is understanding why this topic creates such a strong reaction from both patients and clinicians like us.
Absolutely. And thank you for having me here. I'm honored to be able to bring more attention and awareness to a topic that is in dire need of it. I believe it brings, some tension because patients tend to kind of get lost in the system as they're searching for answers. And I was one of them. My illness started to progress over a number of years, and I went from specialist to specialist in search of those answers. But I was chasing systems of the body kind of one by one. And that's very typical of the specialists that you go to. And no one was really helping me look at it from the bigger picture of, hold on, is this a system? Is this all interconnected? A multi-system, multi-symptom presentation. And I think with doctors, it's difficult. This is not something that's taught in medical school. So the knowledge is typically not there in order to recognize it, screen for it, diagnose it, treat it. They feel pretty out of their element, whether, it's a patient presenting and saying, hey, I think mold is a problem. A lot of the time they get dismissed. And if that provider is willing to hear them out, it's, that's not my specialty. It's not my wheelhouse. I'm sorry, I really can't help you. So there's, they're both kind of searching for a lifeboat or of sorts to help them. And that was very much how things evolved for me. And I had to take it into my own hands and start diving into the research. It was my whole my children who were also affected. So it was once I started connecting the dots to our environment and our genes and what was happening in our body, I found answers.
Do you have fatigue, cognitive dysfunction, muscle and body aches, mood swings, increased urination, numbness and tingling, visual disturbances? Have you seen doctor after doctor and can't figure out why? Perhaps this could be chronic inflammatory response syndrome. Stick with us today, and we're going to go over this diagnosis that's a bit outside the mainstream of medicine, and you might find out some things that would be helpful.
For the folks that are listening out there, back up to pre-seeing me the first time. Talk to me about what first made you start thinking, what was happening in your house, in your life? What first made you start thinking, I have to go see something's wrong?
Yeah, it wasn't very obvious initially just because I weight train very heavily. I thought, I work out hard and that's just why my muscles hurt and why I'm tired. I'm a mom of young boys who keep me very busy. Hormones, I don't get enough sleep. It was all of these things that I kind of gave myself an excuse for. But over time, once we had moved into this home, it was late 2019, just before COVID. And then once we were in our home and kind of locked in our home, symptoms really started to spiral out of control. It was full body hives. It was debilitating migraines. It was debilitating muscle pain. And those symptoms just continued to stack. It was one diagnosis after the next. It was POTS. It was mast cell. I was SVT. I was dealing with so many different diagnoses and symptoms. And my children the behaviors were out of control. It was, no one knew what was going on in our home, really, other than me. My children acted different even for my husband. And so no one could quite understand the rage behaviors that I was seeing from my kids. And
how old were your kids when this was happening?
this started with my children. My oldest was 5 and my youngest was 3. We didn't find a diagnosis until my kids were 6 and 8. And it evolved over so many years of watching their health continue to decline. It was not just the behaviors which in terms of a clinical presentation was really pans and pandas that they were dealing with and neuroinflammation, but they had GI issues. We were doing endoscopies on their little bodies and we were medicating, and I was chasing geneticists. And just like every specialist I was pursuing, whether it was cardiology, ENT, dermatology, neurology, every specialist under the sun, I was taking my kids to the same ones. Still thinking, well, they just got the same cards I was lucky enough to get, not connecting anything in our environment.
You wound up kind of blaming yourself a little bit, like I just must be kind of weird. Something must be peculiar about me.
My husband used to say, you were made with used parts, and that was just a running joke that we had, and I couldn't even be angry about it. It was true. It felt like I was pieced together with used parts, and I had just kind of accepted that. Looking back, really, I had health complications that started in my late teen years, got much worse when I went to college, moldy dorm room, and over the course of kind of my adult life, I really struggled, but I was able to get by. And it wasn't until we moved into this home, we were unaware of what was hiding behind the walls. And we were also in exposure unknowingly to sewer gas, which is another biotoxin. There's gram-negative bacteria, endotoxins, that travel through that sewer gas and causes the most brain injury in a number of the biotoxins that we look at. So that was a massive exposure on top of the mold exposure as well.
Lauren, was your husband as affected as you and your children?
No, my husband was asymptomatic.
Yeah, completely not.
So that really kind of shows that genetic predisposition that you and your children, it'd be interesting to see genetically how something like this may be passed.
Absolutely. So looking at the human leukocyte antigens, we look at the different haplotypes one is lucky enough to end up with. And there are certain biotoxin susceptible haplotypes of those antigens that your body can't properly tag, identify, and remove these biotoxins. So they stay in recirculation of your bile. And so my husband was healthy as could be. To a point, it was unfair, but I'm so thankful he kept us afloat. But he was completely asymptomatic, and that's very common, which is why there's a lot of struggle with relationships and partners feeling dismissed because one is healthy and one is not. And but that was even harder to really sit there and identify, our environment's the problem. And then everything we had to go through when we did figure that out was very stressful, because my husband, who is healthy as can be, is like, you're expecting me to move out of this home and gut this home and get rid of all of our items. And I'm healthy as can be. And he loves me. He'll do anything. And he did. But that was tough.
Yeah, it must have been. So can you just back up for a second? Because you're saying a lot of things that folks may not be aware of. The human leukocyte antigen, the HLA type.
Sure.
About 25% of people are susceptible, supposedly, to CIRS, from what I'm reading. But do they actually know what HLA types are the susceptible ones and what aren't?
Yes.
Is this something you can get genetically tested for?
It is. Yes. You can get it done through LabCorp, and that's what we prefer. And it's a sequence of these haplotypes. So a haplotype is when you have your HLA, this antigen looked at, it looks like gibberish when it comes back. So it's really how we piece together the HLA DR1, DR3, 4, 5, and then DQ intermediate. And so, for example, I have a 13652C. Not that that means a whole lot to everyone, but
Right.
that is kind of how we say those haplotypes. So a 13652C is a mold susceptible haplotype. So we have mold susceptible, multi-susceptible, post-Lyme susceptible, and really that doesn't mean a diagnosis of Lyme. That just means they're more susceptible to these different biotoxins.
Just so my background is I graduated from medical school with a distinction in research for immunology. So I just to let everybody know what an HLA is. It's a unique set of proteins that are expressed on cell surfaces that give your immune system, it gives a picture of what it's capable of. There can be variation inside what it's capable of, but the set of proteins that you genetically express determines how your immune system behaves in certain environments. So these designations have been mostly mapped out, but not completely. And so the things that she's talking about are unique to each individual HLA types. Just for some background, so people can sink into it. If you're Googling this or you're grokking it, you're going to look up HLA, human leukocyte antigen, and I think it'll give you a more robust picture of what we're discussing. But I have a question though. Just to back up even further, can you just define what chronic inflammatory response syndrome is, CIRS?
Yes, absolutely. So chronic inflammatory response syndrome is a presentation of multi-system, multi-symptom innate immune dysregulation following exposure to environmental biotoxins such as mold, endotoxins, actinobacteria, the biotoxins we see in a water-damaged building, and then as well as Lyme, vector-borne illness, and even Listeria, kind of contaminated fish of sorts. So it's a progressive illness after these exposures, that master switch of inflammation. I like to try and break down what is a very complex illness into digestible terms. So it's pretty much your body's turning on this master switch of inflammation. It's like turning on a water hose. Those antigens properly turn on that inflammation, which is supposed to be good inflammation, our innate immune response. But what happens, it doesn't hand it off to this adaptive response that's supposed to come in and kind of finish out the threat that's happening in the body. So that water hose gets turned on and then it never gets turned off. So the inflammatory cytokines are continuing to fuel this illness.
This sounds a lot like the inflammatory response that we were seeing with COVID. I'm curious as to whether there's a genetic predisposition for the way people respond to many different types of exposure. So, for example, the COVID virus and/or the vaccine. It seems like,
or the spike protein.
Yeah, or the spike protein. It seems that you've kind of uncovered here something that could be really the basis of all overreaction of the immune system in several different areas.
Well, it's not just the inflammatory cascade, though, right? You have to have a certain haplotype. You have to have a blood-brain barrier disruption, right? And then also the type of inciting event.
Correct.
Is specific to CIRS, right?
Right, but there's still the genetic predisposition.
No, yeah, absolutely, yeah.
So we want to have genetic presentation. We want to have kind of their full history of, is there water damage building exposure? Is there tick bite? Is there brown recluse? And then we also want to have a priming event. So that priming event can be many different things. It could be a common cold. It could be strep. It could be a surgery. It could be a traumatic event. It could be COVID. COVID is a massive priming event. So when we have a patient who is living in a water damaged building, we typically, mold does not discriminate. So we tend to see these different biotoxins in the same environment, Actinobacteria being one of them. And don't hold me to this. I believe there is a paper published on this, but there is a connection between those Actinobacteria and someone developing long COVID. And because of that exposure that has been in their environment, when you look at these long COVID patients, there's a genie, a blood test that can be done, which looks at about 200 different genes that are upregulated in the environment because of the environment. And we can see specifically what this person is responding to in the environment. And we can see Actinobacteria being one that is triggering them. So I also find it interesting that, like Dr. Ben had said, that about 25% of the population is predisposition to developing chronic inflammatory response. And even when you look at developing long COVID, it's, that same kind of percentage of people that go on to develop long COVID. I've worked with many different patients who have a diagnosis of long COVID, spike protein, and all of that presentation. And I had a diagnosis of long COVID. And walking through the protocol, the clinical protocol that we use for chronic inflammatory response syndrome, I no longer, hold on to that long COVID diagnosis.
Are there any particular molds that are more dangerous than others for CIRS? I mean, I know Stachybotrys is kind of the big scare factor because of what it does to your brain and it's overt.
Yeah.
But I mean, what other molds in general?
Yeah. So we look at Aspergillus. That is one that you're going to find across the board in any climate, but especially in humid climates, because Aspergillus thrives in humidity, which is a problem in both just our environment, but if we're not controlling that HVAC system and dehumidifying it in our climate. So Aspergillus, Cotomium is also toxic black mold. Debatable, is like Stachy or Cotomium, which one's kind of the same thing. So they're both super neurological. And then Willemia. So Willemia is another one that we look at. There's 36 different indoor water damage molds, but we look at the top 5 that I just kind of mentioned. So there's 2 different species of Aspergillus. So we look at those top 5 and then we get a score based on that. That's not the whole picture, but that score helps me help a patient to understand how healthy is this environment for your healing? Are we going to have a successful clinical outcome here? Or do we need to dig deeper? Do we need to evaluate? And what species do we have coming back? So that I can kind of help, all those puzzle pieces I was talking about, that's part of it. So understanding how to dissect these tests helps them kind of make sense of their environment and what we have to do.
We're in Houston, and there's an enormous amount of mold exposure. Mm-hmm. Why is this different than when somebody gets like allergic fungal sinusitis from, or they have Stachybotrys in their house and they get exposed to that? How do you know that? Like, what's the pattern? Is there a generalized pattern of CIRS of symptoms, or is the fact that it's disparate symptoms over many organ systems that should clue you in?
Very good question. So a lot of the time, I would say kind of, there's different ways you can look at this. There's a lot of people who don't even believe in mold. And then there's people who kind of look at mold as it's an allergy. And then, we look at there's mold as mold toxicity, and then there's chronic inflammatory response syndrome. And so when someone has been exposed, a lot of the time, looking at IgG, IgE antibodies can show us if somebody has a true allergy to mold. That's a very real thing. Someone can also have CIRS and not have an allergy to mold. But when we're also looking at IgG, IgE, we know that we're looking at some memory antibodies, whether there's been exposure, is there ongoing exposure? None of that is a diagnosis of the multi-system, multi-symptom presentation of CIRS. So we do want to, there's a very simple way to screen for this. And if somebody is coming to you, to any provider, with that multi-system, multi-symptom presentation, screening them is one of the most simple things that they can do, which is just using a VCS test. It's a visual contrast sensitivity test to see if they can distinguish the patterns of gray and white, because that optic nerve is going to be inflamed with biotoxin exposure. So we typically see failed VCS. There's about 10% of people who will still pass that. Then we're looking at the cluster symptom list. So a cluster symptom list is very useful when we're looking at a diagnosis for a CIRS patient, because even if we have the different blood markers coming back, if they are asymptomatic and don't have those cluster symptoms, that is not a diagnosis of chronic inflammatory response syndrome. So when you have a patient look at that cluster symptom list and they can go check, 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 check. So it's looking at different symptoms across different systems of the body. And if they have 8 or more of those different cluster symptoms, then that is consistent with a CIRS diagnosis.
Dermatologic, I mean, this has really opened my eyes, Lauren, because we deal with a lot of patients that come in with mold exposure, but I have a small but real spattering of patients coming through where you can't really put your finger on what's going on, but it seems devastating to them. And I wonder if some CIRS patients have passed through my halls.
Oh, I know they have.
And I've missed it. I clearly missed it in you, and that's why I want to embrace it and try to understand it more, because I've always, my journey's always, I was 20 years in the military. My journey has always been about how do we fix this person, not about getting them through in a 7-minute visit so I can keep my salary up.
Sure.
It's always been, it's been a labor of love for me to a certain extent.
No, and I greatly appreciate that. It's always, having been the patient myself and now helping others navigate it, anytime there is any provider, and especially MD, and willing to hear it out and learn more and realize that there's still a lot to learn and we don't know everything, is so refreshing.
Well, you want to be a student your whole life. Lee will tell you, right, Lee? I mean, you're always learning new stuff. We were just at a conference called Moment in Dallas, and Mark Dean gave a talk that I just had explosions in the back of my head about it. He brought up some data that's earth-shattering, in my opinion, because it put together little quips about people over the past 20 years, 30 years, that didn't make sense, and he's figured out this very small thing about the eustachian tube and about hearing and whatnot. And so it happens all the time for us, and that's why we get together. Why we get together. We're supposed to be hungry to learn all the time because we don't know everything. Mm-hmm. I think, unfortunately, the pressures that are on our current healthcare system tend to push away from. Remember, doctors were scientists first, and then and treating patients second. That's no longer the case. There's an industry, and it's totally separate from medicine, and that's unfortunate because we're the ones out there seeing patients.
There are religions now within medicine, right?
Exactly.
Yes.
Where you have, if you deviate from the religion, you're a heretic.
100%.
Yes.
I mean, you brought up Mark Dean. Mark's work on pneumosinus dilatans is just, I think it's groundbreaking, and it's
absolutely,
people have to hear about it.
So we're probably going to do a whole episode on that. I'm going to visit him this summer with my whole staff. Actually, we're going up there. We're going to see about 20 patients together on a Thursday, Friday. But it reminds me of Lauren, though, because he didn't give in to. Listen, you're not understanding this. You gotta get with the program. He was like, no, I'm seeing something different here, and that's what Lauren was saying. She's seeing all these doctors who may be well-meaning. They may have been dismissive, but they were in there working, they're doing their own thing. And she's like, no, this is not what's happening to me. You guys aren't answering it for me, and I know something's wrong with me. Lauren, look, we're both physicians here. We see patients all the time. I saw you. I focused on one part of what was going on with you, and I failed to diagnose you, which is why you're here, because I find what you've done fascinating. What are the symptom clusters that a patient might present with that might start a doctor saying to himself, hey, this may be CIRS?
Absolutely. So we have 13 different cluster symptoms, being fatigue, weakness, there's aches. So you're going to have general muscle aches, pain, post-exertional malaise. And then there's memory and cognition. So memory impairment, difficulty concentrating, word recollection, brain fog, definite decreased ability to learn. Ice pick pains and sensitivity. So ice pick like pains, that was a big one for me. I felt like someone was stabbing the back of my head. Unusual pain sensitivity, joint pain without swelling, morning stiffness. Cluster 5 is headaches. So we have pressure, migraines, tension headaches, very common for people. Light sensitivity, vision, that's a big one. Blurred vision, a lot of people are chasing, I'm getting an eye exam. Everything looks good. And that was not eye related, but just as you had said, I was in your office because I was dealing with, I don't feel like I can hear well. There's so much pressure in my ears. The tinnitus is so loud. It's all I can focus on. I did have some minor hearing loss because of shingles up the back of my head. And, but a lot of these things, people are sitting in an office and being told everything looks good. So, light sensitivity and vision is a big one. Sinus, respiratory, shortness of breath, abdominal, GI, a lot of people dealing with IBD, IBS, static shocks. That's a big one. Unusual, unexplained sensations in various locations, internal vibrations, appetite swings, temperature fluctuations, thirst, frequent urination, metallic taste in someone's mouth. That's also a very common one. And then we have skin, mood, neurological. So skin sensitivity, a lot of people dealing with unexplained skin rashes and things like that. Mood swings, depression, anxiety, irrational fears, vertigo, dizziness, numbness, and tingling in extremities.
So that's a massive list there, and I can definitely see, first of all, why it was confused with long COVID. I can also see why, when not put together in water damage building, exposure to endotoxin, and HLA, a particular type, I can see why it can be confusing for physicians that you're coming, and for the patient itself that you're coming in. I can also see a role for overdiagnosis of it too, because a lot of people have headaches and stabbing pains, and they're not from that at all. And people have skin sensitivity and allergy, but it certainly is comprehensive. I mean, that's many organ systems. Have they worked out how often each of those occur? And is there any one that is very specific for CIRS?
Oh, that's a good question. I'm so immersed in this that I see these presentations and these patients and their symptoms on a daily basis. And the majority of them present with a vast variety of these, not one, not in one cluster. So we're not just dealing with headaches, but it could be someone who is dealing with those symptoms spread out across a couple of different systems of the body, not quite as severe as where I landed because mine was undiagnosed for so long. And so just like, the overdiagnosing, we definitely don't want to do that, which is why the screening is so useful, the VCS, paired with that cluster symptom. So really, we're not saying, do you have any of these symptoms? We want to know, do you have 8 or more out of these different cluster boxes? So 8 of those symptoms is reason enough to go on to look at the biomarkers of inflammation.
Is it eight symptoms or 8 systems that are affected in one way or another? Or can it be any 8?
So we want to have 8 symptoms in 8 of those at least 8 different systems.
8 systems. So you want it to be systemic. You want to see that
Correct.
it's affecting all kinds of disjointed things that you can't put together into one diagnosis.
Correct.
Interesting.
Which brings up the potential outlier that only has 7, right? So,
Yeah.
I think that when you make things so specific, if you say, well, 8, we're not going to look into it. If it's not exactly 8, well, the person that has 7 that maybe can't characterize the 8th to you appropriately.
Right.
So I think you have to have a little bit more of a heightened index of suspicion over, the rigid, it has to be 8. I would think anyway.
There's a lot of, it being rigid in this framework. And so I think that if you're asking textbook, that would be textbook. But when you're working with someone and you see this so frequently, you tend to say, this is still worth pursuing. This is still worth running these biomarkers and even having them look into their environment. Because if we're going to dismiss this based on you have 7, not 8, that's not reason enough to move on and kind of fail that diagnosis with someone. I have even seen where, it wasn't necessarily they are sometimes so focused on one symptom because it is so extreme and so severe. It's dominating every other symptom, and even erythromyalgia, where their hands and feet are on fire and burning is CIRS, and going through the diagnostics and treatment can completely alleviate that symptom.
That's a great. I didn't even think of that, Lee. But Lauren, that's a great sort of moment to stop for any clinicians that are watching this. How often have you had a patient that has a massive deviated septum, can't breathe through their nose, and tells you they breathe fine through their nose? When you're focused on something, like you said, like something's terrible is having your feet and hands burning, you're not going to want to talk about the subtlety of some headache or, so if that's your whole world, if that's the key thing you're focusing in on, you might miss a lot of those other things or not even be willing to talk about it. So I think it's the entire thing, the VCS, the water damage building history, your HLA type, I think, and then symptom clusters that seem like it's that it might be in the CIRS range without being sine qua non,
Mm-hmm. Absolutely.
So are we looking at this then, Lauren, as something that's going to, in your opinion anyway, going to end up being a diagnosis of exclusion? So you go through the whole rigmarole and nothing else seems to come out, and now, okay, we're left with, we can't figure out what this is. Let's explore CIRS, or are you saying that, hey, look, if we've got these 8, we should be going right to this as one of the potential primary diagnoses right off the start, and not looking at each system and trying to figure out if we have more than one thing going on, kind of an Occam's razor type of situation.
Yeah. I am so glad you asked that question.
I did want to say one thing, though, Lee. Until we characterize how common this is, we're not going to be able to answer that question, really, because sensitivity and specificity are exquisitely dependent upon the frequency in the population, right? So if this turns out, if 25% of HLA types in the population are possible candidates, it could be much more common than we actually think. And so I think we're just in the infancy of trying to understand this. And I miss this so easily. And it's so apparent now that I know it, that she was going through it. I wonder how many of our other patients that we bump into that we don't think have a problem actually have CIRS. And if it is super common, then it may not be a diagnosis of exclusion anymore. Because if you have the haplotype, we're going to start to characterize things a lot better and be able to hone in much more quickly to rule them out or rule them in.
Yeah, but let's not fool ourselves. If it doesn't become mainstream enough that insurance is going to pay for the testing,
right,
it's going to be very difficult to keep it anything but a diagnosis of exclusion.
But again, the truth is the truth, right? And so our system may refuse to or be unable to be open to it. But that's not going to change the fact as we figure this out and peel back the layer of onions on this due to people like Lauren. It may wind up being that it's much more common, regardless of whether insurance wants to acknowledge it or not. But to your point. Right now, Lauren, is it a diagnosis of exclusion?
I don't see it that way. Having been the patient and working with people, my goal in doing what I do, and I hope that on my deathbed I can say, we're beginning with this. We're looking at this first, not last, and especially because if someone is coming to you for the very first time and you're able to ask a few questions and right there you're suspecting that they may be dealing with CIRS, do a VCS, look at the cluster symptoms and then pull some biomarkers. If all of that adds up right there, you have a pretty solid answer that has a clinically proven treatment plan to help this patient rather than directing them.
What biomarkers would a clinician look at? Are we talking about MMP, TGF-beta? What would we actually send and look for? Is there a LabCorp thing that you can say CIRS screening?
I believe that they recently came up with a CIRS panel through LabCorp. Don't hold me to that. But for any clinicians who are listening that, in order to help their patients, following the, shoemaker criteria in terms of those biomarkers that we're looking at. So TGF-beta 1, MMP9, MSH, vasoendothelial growth factor, leptin, C3A, C4A, and then we even look at, testosterone and DHEA because of the hormone imbalances. So those are, really the top three that you can run to really kind of, do we need to pursue this further, is going to be your...
Where do you get VCS done? Who does VCS testing?
There's a couple of different online websites. So you can go to survivingmold.com. You can go to I think it's VCS test. I'm currently working on one that kind of is using all of them to kind of put together a very effective free VCS test. But it's done. You can do it on your phone. You can do it on your computer. I recommend doing it on a desktop when you can, making sure the screen is properly calibrated.
So you can do it at your home. You don't have to go to a big center or a hospital to have it done.
Correct. You can just tell a patient, go home, do a VCS. Let's look at these cluster symptoms. I'm just going to start by running your MMP9, your TGF-beta 1, and MSH. Let's go from there.
So Lee, to your point, that might be a lot more doable just to sort of rule stuff out.
Yeah, understanding that there are many different things that can cause a VCS to be abnormal. The caveat to that is not to tell the general public, hey, if you think you have something, go do VCS, and then all of a sudden you have a bunch of people freaking out saying, oh, I have CIRS.
Overdiagnosis is a problem.
Kind of thing. Yeah, it still has to stay in the hands of the clinicians.
Yeah, it's not just a positive VCS. It's all these other things.
That's what I meant to say before, though, when I said the frequency of this in the population is going to determine what's over and underkill. Because if it turns out that CIRS is a lot more common than we thought, and we're underdiagnosing it, then we're going to have to return to all this and decide that this is one of the things you rule out, like MS and long COVID. This is actually going to be something that you send a couple of quick tests for just to make sure it's not CIRS, but only if it's really prevalent.
Correct. And to, your question earlier about the MS diagnosis, it was my body was failing me, no doubt. It was every system, every symptom. I was a bodybuilder who became bedridden. I wasn't able to pick up the same weight with my left side that I was my right side. I wasn't able to drive anymore. And a neurologist, an MRI showed UBOs, unidentifiable bright objects on my brain, not consistent with lesions seen with MS. unfortunately feel like I was failed by this neurologist who was very dismissive of me, and said, we really don't know. Let's just call it what it is. And because of your symptoms and because of what we're seeing, it's just atypical MS. And that didn't sit right with me. And that can happen with inflammation, and inflammation due to biotoxins crossing the blood-brain barrier that has been just disintegrated because of elevated MMP9. So I do not have an MS diagnosis. I do have 4 areas of atrophy in my brain that a MRI neuroquant shows, which measures different areas and the volumes of those areas in the brain and then compares them with a healthy control. So, which is very validating for someone who feels like, hey, I used to be pretty sharp and now I'm having a hard time finding the right words. Or, I was diagnosed with ADHD in my late 30s. I never had that diagnosis before. And so extremely validating when you feel like you are losing yourself mentally.
Wow.
So let's address the, maybe we'll call it the big elephant in the room. Mainstream media has obviously not come around on this specific diagnosis. Mm-hmm. And, I think much of that is due to most of the literature coming out is from the same group, the Shoemaker group.
Sure.
How do we, and I don't know that anyone else has really even tried to do anything but criticize, right? I don't know that anyone else has actually tried to research this and do anything. It's just very easy to criticize other people and say, oh, well, that's all coming just, from one group and therefore it's not valid. How do we get this out there? How do we get more people outside just the same group of individuals to do these studies and research it and get it more in the mainstream?
I don't know that I have the perfect answer to that. And I'm continually trying to fight for that. And anyone, regardless of what camp you're in and what your beliefs are and kind of where you stand with mold illness or chronic inflammatory response syndrome, even for people who are diagnosed with fibromyalgia, lupus, a lot of people, POTS and mast cell and things like that, when we're pulling the right blood biomarkers and we're seeing what is happening in the body, that gives us clear, and then we're treating that person with the protocol. We see these biomarkers of inflammation resolve, which is pretty clear. So if other providers are willing to look at some of that research and gather some of that data on their patients and see, what was this before treatment? What is this after treatment? Did we see a resolution in their symptoms? Are they doing much better? I think that carries a lot of weight because it's not just a shot in the dark like many other protocols out there. It's measurable, quantifiable markers that are tracked and people heal. So it's you have to look at the bigger picture of the environment and what is happening in the body and fit together the puzzle pieces rather than just attempting to, we had mold exposure, we're going to throw a binder at it and just kind of hope and pray for the best. If you're still looking at just mycotoxin urine testing, that could be a sign of exposure, but 60 to 100% of people, healthy people, have mycotoxins in their urine.
Yeah.
So when we look at the biomarkers, we're getting clear data. That data moves when we treat properly.
And I presume that treating isn't just removing the environmental exposure.
Correct. And that is the hardest part, absolutely, because many people will make the argument mold is everywhere, and it is.
Yeah.
And the hardest part of this is we have to get the building right, which it takes us a lot of money. We have to get the building right, so we have to get the patient out of exposure. And you have to know what you're doing. You have to get them out of mold exposure. But most people are so focused on that mold exposure, they're missing the sewer gas, the endotoxins, the pest infestation, the Actinobacteria, because that is an environmental issue, but it's also kind of it stays in your sebaceous oil glands. That Actinobacteria on your skin is priming that immune response as well. So knowing how to get them out of exposure and then, test and diagnose and treat them with bile acid sequestrants. And we're addressing MARCoNs in the nasal passages, multiple antibiotic coagulase negative staph that kind of you become your own exposure. We have to eradicate that because if we don't, MSH, a neuroregulatory peptide that's almost non-detectable in many CIRS patients, that can't come back up. And if we can't get that MSH to come back up, we're going to be struggling with, continued hormone dysregulation, sleep imbalances, higher pain receptors.
Yeah, sleep imbalance mostly, and brain fog as well with MSH. But
lots of brain
Lee
fog.
and I actually are part of a group of ENTs that use intranasal gentamicin routinely, and it's buffered as well as an antifungal because of things like this, because of biofilms that exist in the nose that hamper a lot of different things, not just chronic sinusitis. So we were acutely aware of that, and we have a really good system for trying to fix that. But did you take cholestyramine at all?
Mm-hmm. Yes, I did.
And you felt like it helped you?
That drug saved my life.
Really? So can you walk us through how you got fixed and the steps that you took in particular? It sounds like you followed the Shoemaker protocol, but you can go through that in general. But what did you actually do to eradicate your array of symptoms?
Yes. Yeah. I was doing a lot before I found my diagnosis. I was biohacking and using peptides, and I was doing everything that I possibly could. And I do strongly believe that. And again, when I came to you, Dr. Ben, I had no idea what was wrong with me. And
right.
I came to you knowing that I have, I'm dealing with like this weird ear stuff. I had allergies in my late 30s that I had never had my entire life. I was not someone who dealt with allergies and sinus infections, and I couldn't breathe. And so I have no doubt that the procedures that you did, fixing my deviated septum and clearing out my sinuses that were full of mold, and got me a step in the right direction, because when I did come to my diagnosis and moving forward, I wasn't dealing with all that. We had removed that, which was significantly helpful. But when I got my diagnosis, and I was actually fearful of using CSM. There's cholestyramine is CSM, which is a bile acid sequestrant. So in the Shoemaker protocol, it is grabbing hold of bile acids, which hold on to these toxins that stay in recirculation, and pulls them out of that bile. We only eliminate 5% of our bile at a time, which is not very much. So when you have these HLA presentations, your body can't clear these biotoxins properly. Those toxins are just staying in recirculation. We have to stop that enterohepatic recirculation, get them out of the body. So I was fearful of taking CSM because of the fear that is out there on Facebook groups and the internet and Google and things like that. And I thought, well, if I'm not tolerating any other protocol, I can hardly take a supplement without erupting in hives and feeling like my throat is closing and my brain spinning out of control. I thought there's no way I can tolerate CSM. And but I continued to decline. And my husband was the one who, after really diving into the research, was like, I don't think you have any other options here. I think it's time to give CSM a try. And I did. And it was, many people hope that it will be like taking an antibiotic. If you've got pneumonia, strep, you take an antibiotic and, 24 hours, you're a different person. You feel great. And that is not the case when we're taking cholestyramine. It is going to cause some mild flares, but we do a lot of priming the body beforehand to calm that down. And so a lot of my neurological symptoms increased when I started binders, which is cholestyramine. And but I was able to tolerate it. And that's what I tell a lot of my clients is you have to be able to tolerate it. If we have severe neurological increase in depression and suicidal ideation and those things start to increase, that's not tolerable. We need to pull back. But starting this binder was slow. The progression was slow. But after about 2.5 months, I felt like the clouds were parting. I woke up one day, and for the first time in a very long time, I thought, you know what, this life might actually be worth sticking around for. And I stuck with it. And little by little, every symptom, every diagnosis that I had previously had, it was like I was erasing it, from my list. And I had interstitial cystitis for about 18 years, gone. I had severe pain that I was getting epidural steroid injections for in my cervical spine. That pain started to dissipate. My derealization, my depersonalization, my suicidal ideations, my shortness of breath, my everything started to resolve. And I started to feel like myself again.
So this was really a dark time for you. I mean, you're talking about not wanting to go on. And people listening, there's bound to be people out there that are like, holy cow, that's me. And this was a leap of faith for you, and you stuck it out for 2.5 months before you came to the realization that it's helping you. I mean, that must have taken a lot of drive.
A lot. And that is, I hope it's okay that I mentioned that. I think I'm very open with.
I think it's important that you do. It's important that you do, because it's going to be speaking to a subset of folks that maybe, keep looking. If they have something that sounds like this and they've given up because they keep getting turned down, maybe keep looking, maybe get the right set of tests done and maybe get some answers.
Yeah, absolutely. And even those who already have this diagnosis or in the thick of it, in the throes of going through it, knowing that you stick with it and it can get better. There is hope. But again, if those things get worse, we don't want to push through. We need to stop. You need to consult with your provider, make sure we're supporting you the right way, that we're not still in exposure and things like that. It was an incredibly dark time in my life. I've been through 4 pregnancy losses. I lost my dad to brain cancer. I watched him take his last breath. I've had a lot of loss and a lot of trauma, and this was by far the hardest season of my life. And being a mom who was kind of in this place while trying to also be the person who was fighting for my kids and recognizing that they are going down the same path that I am. My children who were expressing to me things you shouldn't hear from like a 6, 7, 8-year-old in terms of they're battling the same dark demons I am. This is not normal. This is absolutely not. And so it was hard. I didn't want to be here, but I felt like, who else is going to fight for my kids the way that I am? And so I tell everybody that protocol, that cholestyramine saved my life. And it changed the trajectory of my children's lives. And they are different kids. And, my husband and I always say, we feel like we're getting to know them for the first time. We're just sad it took this long, because they were just parts of them, their personalities and what they were going through at such a young age, which kids can't really express to you. They don't know what's normal. They don't know what it feels like to maybe not feel that way. And with the cluster symptoms in children, we look for 6 of those cluster symptoms, not 8. But it completely changed the course of our lives. And my husband got his wife back, got his family back.
We're still so in an infant type mode with this medically. We really don't understand it very well, and there's almost no awareness. But because there's a potential for a lot of people falling into this category, we're kind of riding this razor's edge between overdiagnosis and overreaction or underrecognition. And until we figure out where it sits in the prevalence in the population, we're not going to really know how much attention to pay to it. But it's obviously horrible in your case where it just went undiagnosed for so long and was allowed to. I mean, 3 years, right?
5.
That you felt like your whole life was ending and you had no answers from anyone. So how do you separate thoughtful investigation from fear-based medicine? Both have potentially pretty negative impacts on us as a society and on individual patients.
Yeah, I think that, when being the patient, walking into any provider's office, there's some questions. Sometimes, there's an intake form. There's things that we go through, these processes. And I'm not trying to sit here and say that everything out there is CIRS. When you start to see it, it's hard not to put this on people's radar and at least say, hey, please at least screen for this. There's no harm in doing that. I think that if providers had some sort of an intake form where we're looking at this cluster symptom list, we're asking patients, hey, have you ever lived in a water damage building that you know of? And hearing them out, hearing, what is going on. If they're coming to you, maybe as an ENT, but they may not be telling you, I'm also seeing this dermatologist and this neurologist and this cardiologist and rheumatologist, and piecing that together. But if we're looking at a cluster symptom and saying, hey, have you, maybe just consider this, or, if you're in the position to run some biomarkers and rule it out. And if that is not on their radar, or if it doesn't seem like that is worth pursuing, we don't have those cluster symptoms, biomarkers look good, we don't have to over-diagnose, but at least we're not letting those other people slip through the cracks. Had that been something that was done early on for me, I would have been immensely grateful. And I feel that if we could start there rather than ending there by ruling out every other diagnosis, because mainstream medical, if I go to someone and, my diagnosis of POTS, I don't have POTS. And I also had SVT, and it was very difficult, but my ADH was low, my osmolality was high, so that antidiuretic hormone and how my body was holding on to fluids.
Are you using VIP nasal spray at all? That was a part of your problem? Are you using the VIP peptide?
Nasal spray.
Okay, and that's helping?
Yes. So yes, that absolutely, it's phenomenal.
Sorry, that's vasoactive intestinal peptide. Sorry.
Correct. Yes.
The VIP.
Yeah. So that is typically the last stage of the protocol, because we're using it to a number of different things. We're helping with repairing, the leaky gut and the gut junctions, and it's helping with, it's an immune modulator, it's anti-inflammatory. We're helping to down-regulate those genes that have been upregulated. And then for people like me who have brain atrophy, that VIP has also shown in pre and post neuroquants to regrow that brain matter, which is pretty impressive. So it's pretty phenomenal. Yeah.
Lee, I was thinking as she was saying this, what might be the easiest thing for us to do to kind of thread that needle between overreaction and completely missing diagnoses is developing a quick one-page questionnaire that's a little bit more in depth, and that we can target people who were in water damaged buildings and they check that off on their intake form. Plus, we're starting to hear something that makes us think this may be bigger, and then we can sort of give them that questionnaire in a focused way on people that are not fitting any diagnoses for us. What do you think?
Yeah, well, great minds think alike. I had written down on my pad as she was speaking, create CIRS questionnaire.
Right. I
love that.
So I did one more step than that. I leaned over and I was playing here, and I had Claude draw one up for me.
There you go.
So I already have the questionnaire ready to give them, But my question to you is, I knew you were doing that because I could see you looking down. But my question to you, though, is in a focused way, do you think like you pick out these people that are like, something's not right here? And I see them every so often. I see especially the sharp pain somewhere in their head that comes on, and it doesn't fit the typical fifth nerve feedback loop or a neuroma somewhere. But I've heard that over the years, and with people that are chronically ill, and I wonder how many of these that I've missed.
This is exactly what I do for my clients who come to me that I work with clients who come to me who have already been diagnosed and are working with someone. And really where my job sits is I'm the intersection between the environmental biotoxins and helping them navigate through remediation, everything properly. And then I am also trained and certified in the protocol. So I work with a lot of patients who are working with a primary who can prescribe. I'm not a licensed prescriber, but I'm guiding that protocol. I do a lot of consulting, and I have documents that I send out to them. One is a CIRS patient advocacy form, and another is a clinical for CIRS for clinicians. And so both of these they're able to print out, fill out, and take with them to their provider. That gives their provider, this is what I need to know, this is what we're looking at. And then I give them, the key like research papers in terms of like, here you go. This gives you a basic summary of how you can help your patients. And so I love that you guys are doing this. And I hope everyone does that's listening to this, because that is how we can kind of meet this before it begins to turn into an atypical MS diagnosis, such as myself.
So we're both doctors, and we just focused for the last 10 minutes or so on what doctors should do. What should patients who feel chronically unwell, what would you want them to understand as a final takeaway from this episode with us?
Yes, as a patient, if you are navigating, your whole job has become going to doctor's appointments and chasing diagnosis and symptoms, just as you were saying, on the medical side of things, as a patient, you are able to perform that VCS test, which we know everything doesn't weigh on that or ride on that, because you can have a failed VCS, meaning you can have, you can be negative for the VCS, meaning you've passed it. And that still happens to 10% of people who do have a CIRS diagnosis. Some of the people who are even in the worst of it. And so we don't want to rely on that alone, but they can also pull up those cluster symptoms online and take a look at those. They can ask themselves their own questions of, have I ever lived in a water damaged building? Oh, I have, but I never really thought about that impacting my health. Am I already diagnosed with Lyme? Have I been actively pursuing Lyme and been dealing with chronic Lyme for a very long time? You should absolutely look into a diagnosis of CIRS if that is the case. And so a lot of people, you can also go to my website, the Biotoxin Lady. I put a lot of this together so that there's a screening tool there. You click on it, you are taken to that VCS, to that cluster symptom, to those labs that you can order without an ordering physician, and kind of take it into your own hands, just like I did. I went to 5 doctors with the LabCorp codes, asking them to run these labs for me, and I was told by 5 different doctors, no, I won't do it. And so I found, kind of had to do it myself. I took it into my own hands, got it done, and really had to diagnose myself and then find the right person to work with to treat me. So becoming your own advocate, education is our greatest tool. Like, I will say that until the day I die. Education is so important, to educate the homeowner, the patient who's walking through this, because it's multifaceted. We're cleaning the environment, we're treating the body, educating the medical providers, educating the environmental professionals who are inspecting, remediating, and doing everything, because that's a whole other conversation on that aspect. But just learning, and what I've done and how I've developed what I have a membership and I work with patients, and clients, and is helping them digest this in a way that they're educating themselves, but when you are dealing with a brain that is on fire, a brain that cannot make sense of anything, you are in analysis paralysis. And I didn't have something to help me through that. So that's why I very intentionally, this is step one. This is what we're going to do. We can come back and revisit this later, but what is going to be priority? And I help people understand how to advocate for yourself, how to fight for yourself, how to get these tests done when no one else will believe you. And also helping people find the providers who will help them and kind of put them in touch as well.
Wow. Powerful.
Thank you.
Seriously. Like,
when the number of times I was sitting in your office and had no idea what was going on with me, not a clue. But I can remember coming in there at times and, when I look at pictures of myself, I actually have a picture of myself in your office in that chair. My face was so swollen. It was so hard to keep my eyes open. You get really good at masking yourself,
Sure.
like coming into the
Sure.
public, going to doctors, and kind of, you have to look awake. And my face was so swollen. My eyes were so heavy. The pressure in my head was so extreme. And there were times I had to have someone bring me to those appointments because I couldn't drive. And, so a lot of the time, patients won't always bring everything up because they're so tired of being dismissed. And they're so tired of being looked at sideways. Like, oh, we're just going to label you as an anxiety. I never had any expectation that I would come into your office and you would diagnose everything that was going on in me, right? Like, I want to make that clear that I don't feel like you failed me. And I mean, you helped me, all the procedures that I had done, but I didn't know that the allergies I was dealing with and the sinus issues that I was dealing with and how severe everything had gotten was a result of my environment over many years. And so I think when you can also, in the line of work that you do, recognize, have you always dealt with allergies? How long have we been dealing with sinusitis? And was there a new home? Was there a new environment? Like, kind of what changed can also be really helpful in identifying those things.
it's very helpful. But again, until we figure out the prevalence of this, we're not going to know what our sensitivity and specificity is for any of this stuff. And looking at Claude and open evidence, no one knows that right now with CIRS. It's actually very new, and people are sort of struggling with it. There are a lot, of course, as you know, Lee, there are a lot of detractors, a lot of people saying, it's bullshit,
Well, but this is the problem. This is the problem that we always face in medicine. So you have someone, they're given a treatment, and they're better. And you have someone telling you, well, that doesn't exist. Well, if it doesn't exist, how did I have someone, they received a treatment and they got better? How are you going to explain that?
Right.
And the answer is either I don't know, but it's not that, or it must be placebo, right? That's what you hear every time. And then 10 years later, what you're talking about has become mainstream and it's the way to treat it. So, it's the problem that we face constantly.
That's right. All the time.
Absolutely. It is. And there's a lot of it is young. It's in its infancy. I mean, it was Dr. Shoemaker discovered it unintentionally 30 years ago. And, in the late 1990s, and that's still very new. And there's a lot of data. There's published papers as recent as 2026. And, but there's, even dealing with the medical side of this and the treatment, the diagnosis of everything, there's a lot that needs to change in terms of the buildings, the way buildings are built, and to prevent these issues from arising. And I'm honored to sit on the board of directors at Change the Air Foundation, which is focused on policy, research, and education in this area to fight for the recognition of the diagnosis, as well as fighting for, building codes and laws and everything be changed.
So that's a whole other topic, because my wife and I talk about this all the time, and it's extremely important, is the degradation and the devaluation of general contractors and what they're supposed to know. You don't even have to be a general contractor to build houses right now. And You used to have to be a member of one of the trades and pass a detailed examination to become a general contractor. You don't need any of that anymore. And the people we run into as contractors who are building homes don't seem to know what the hell they're doing and are incentivized to build with the cheapest, crappiest stuff available. So I'm not sure that we're really equipped to deal with the massive amount of mold that exists in, for instance, Houston. Houston is a mold-generated city, and we don't build houses to prevent it.
No, we absolutely don't. And it all comes down to understanding the building science, which again, that's a whole other podcast. But the building science and the way that homes are built, the biggest takeaway though that I hope people hear from this is that mold exposure and dealing with these biotoxins in your environment are not, the most common cause is not water intrusion. It's not, leaks in your home. Absolutely, that's a problem. It is your HVAC system, because the improper design of these buildings, and a lot of people are not doing a manual JNS, which we're taking into consideration the heat load calculations of a home and what the size of a unit needs to be and the design of the ductwork and the, do we have a conditioned attic space and so forth. And because of that, we had mold in a lot of places, but the majority of it was our HVAC system. So it's hidden. And we had sweating in the walls because of hot and cold air, and the condensation. So we had toxic mold growth inside of our walls that was also invisible. And so you go into a lot of buildings, whether it's medical buildings, grocery store, restaurant, there's mold everywhere. And so I want people to know that if this is something you're pursuing or trying to heal from, don't let that stop you in terms of this is not going to be possible. What's happening is when you're dealing with CIRS, that immune dysregulation, that innate immune overactivation is pumping out that inflammatory cascade that we have to stop. But your toxic load, I always say it's like a glass of water is filled to the top, and everywhere you go, it's overflowing. We have to get it to the point that we're dumping out that glass of water, and your home environment where you spend the majority of your time is cleaned up. We can start to heal. And now I can go anywhere. I can go to these places that I know is going to have exposure. I'm going to be okay. But there's tools and there's things that I can do to focus on immune modulation, take binders if I need to, cholestyramine. I will never be in that same place that I once was ever again, because now I can be proactive. And so I want people to know that, because it is extremely daunting. It's extremely overwhelming. It's complex. It's nuanced. But it works, and it's amazing. And once you get your health back, we have a lot of debt. I can assure you that, because taking this home to the studs, redoing the HVAC system properly, redesigning our building envelope, I can appreciate not everyone has the ability to do that. And it's heartbreaking. I work with those clients. I have clients who are living in their car. They're living in a tent. Some of them with 4 kids. Okay. This disease, this illness, I should say, is devastating. And so it takes a lot of work, but when you can focus on the right things, you work with the right team, and we're fitting together all the puzzle pieces. I always say it's like a 1,000-piece puzzle, and you're missing 500 pieces. We have to fit them together. And when we do that properly and we support your body properly, you get your life back. And that is the goal. So we don't want you to live in a bubble. We may need to initially, but we want people to get their lives back and go on to be, with society and go to a restaurant and do all of those things. But one day I do hope that what we're fighting for, those building codes, those laws and standards change.
I love that. Environmental illness is in a very difficult space in medicine, because patients can be suffering deeply while the science terminology and clinical framework is still evolving. We're still trying to figure this out. Shoemaker may have described it 30 years ago, but until recently I had never heard of it and didn't know it until you helped me with that to continue my learning. It wasn't part of Lee and mine's medical training, but we are still scientists, and we're still very open to things like this, and you've really helped us understand and navigate the complexity and nuance of this. And so I think you're helping many people do that too. So as it starts to evolve, I think we're all going to do better because of conversations like this.
That is my hope. That is why I started doing what I do. I did not set out to be an influencer, to build a business. It just evolved. It evolved through my story. And so I hope that my story, my pain, can turn, has become purpose for other people and leading them, kind of giving them that framework to fight for themselves and get their diagnosis.
Have you gone down the fibromyalgia, chronic fatigue syndrome, the autoimmune disorder of the weak pathway? Maybe you actually have chronic inflammatory response syndrome. Learn about these and other issues that affect your daily life by sending this podcast to a friend and subscribing to the Vital Discourse podcast.